formed, and how they are then transported from the in the circulation using the thyroxine binding globulin. And from there, they have a local metabolism using either the activating MDI1 and 2, which convert T4 to T3, and reverse T3 is produced by DIO or MDI3. Then they are transported using MCT8 into the thyroid, into the cells where they are acting. And today we'll focus about the thyroid receptor. So Dr. Sayan, which group does the thyroid receptor belong to? The type of receptor? Nuclear receptor. And what is the characteristic of this receptor? Key features of this nuclear receptors.
After binding of the thyroid hormone to this receptor, it undergoes dimerization with retinal acid.
No. What are the features of nuclear receptor, I'm asking?
It needs a transporter to be able to.
No, I'm not talking about thyroid. I'm asking about what is the feature of nuclear receptor.
So mainly for steroid hormones.
So the features are that it is in the cell, of course, and then it acts via the alteration of promotion of particular genes. So it's basically a transcription factors. So what it does essentially is it is switching on or switching off a few gene transcription. So based upon that, compared to a peptide hormone, do you think that they will have a faster action, slower action?
Slower action.
So they will have a slower action which will be there, and these features will be important from that perspective. So we'll discuss a bit about how this thyroid hormone acts. So normally what we see is that thyroxine, as we discussed, and this is what he was saying, is not going to cross the cell membrane. It requires a specific transporter like MCT8. There are other transporters. We discussed about 3 specific transporters, MCT8, MCT10, and the organic, the anion-based transporter. They are important, but MCT8 is the most important. This will act like a chaperone and it will take the MCT8 inside. Now, once thyroxine reaches there, it will then bind to the receptor, and this receptor will, as you were discussing, dimerize, or it may monomerize, also rarely can join the specific elements, but it will dimerize to be more active to act upon the hormone response element, which basically are what? What are the hormone response elements essentially? So they are?
On that, the hormone can work.
No, what are they actually? In terms of actual genetic level, what are they? They are the promoters. So basically what you are doing is that your hormone is going in binding to that promoter region. We talked about promoter and regulator. I'm not going to ask again what is promoter, what is regulator, but essentially promoter is situated on the cis side, just before the genes, always very close to the genes, and it will decide whether the gene opens or closes. So these are basically promoters where it will act and it will say promote the gene expression. From that perspective is what happens in that regards. Now, how does the same thyroid level will act at different tissues, Dr. Pratik, in terms of what is the basis of different actions of thyroid in different tissues?
It depends on the type of receptor alpha and beta.
Yes, so it is the receptor isoforms. So when we talk about different compounds, we'll know they have different sort of a thing. So what happens with steroids? How do the steroids have specific action?
Steroids have specific action based on the, for example, 11 beta where it is inactivated like that.
So local metabolism and the local, we'll talk about how they act via the activators and repressors they recruit. Estrogen has a different action based upon 2 things. It has got estrogen receptor alpha and estrogen receptor beta, which is different types of receptors which are located in different areas. Second, estrogen will have different number of repressors and numbers of activators which will decide which gene it will activate and which gene it will suppress. That is one mechanism. Glucocorticoid has got single receptor. So there is no glucocorticoid specific type 1, type 2 receptors or something like that. It's the local metabolism, the local delivery which will decide. For thyroxine, however, we have got different isoforms which are available, which will depend upon the tissues in that perspective. So there are 2 specific regions from which it is coded, TRA, which codes for alpha, and TRB, which codes for beta. And based upon that, you've got different isoforms which will work, and we'll see how they act differently. Different tissues will have significant factors in that regard, which will allow site-specific action in that regards. Now, thyroid receptor, as Sayan has said, is basically a nuclear receptor. And when you talk about a nuclear receptor, what are the major parts of a nuclear receptor, Dr. Manoj?
As we discussed, it should attach with the promoter.
No. What are the parts? So that we've discussed. So let's put it this way. Its work is to attach to the DNA or the promoter. So there will be one
Ligand binding.
So first of all, it will obviously have a ligand binding site. The ligand will bind to that. Now, what is this ligand binding site made of? What is the structure of this ligand binding site? It's typically a helical structure. And when we talk about thyroid, there are 12 helix which are there. Now, this is very important because by the binding of the ligand to that particular ligand binding region, its structure changes. It's like you got some key and you put in the key, the door opens. So the molecules which are attaching to it will become different. And this becomes relevant when we talk about that. So one is the ligand binding region. Then second, so after that, you will have one which will take it to the nucleus. So they are in the cytoplasm, it will move to the nucleus. So there is a nucleolar organization or localization region. And then, of course, you will have the DNA binding region, which will bind to the thyroid response elements, which are basically the promoters. And you have a trans activation region, which activates other aspects as well. So this is a typical structure of a nuclear receptor, also there for thyroid. Now, basically, if you look at it, this single receptor can also act. It can also go and act in the nucleus, but its potency affinity will be much less. So best is that when two meet together, dimerization happens. And as discussed earlier, you can have homodimerization or heterodimerization. And for this, the best is to dimerize with the retinoic acid receptor, the RXR, which will give it some maximum potency. Now, this increases its action. Homo and monomer have got lower action and reduced activity. So this is how. So you've got the thyroid, which has now come to the cytoplasm using MCT8. It is bound to the receptor. They merge, and two of them then take them together to the nucleus, and they will start there. Now, within the nucleus, how do you think it will cause the stimulation of the action, Dr. Naveen? So this is what we talked about. These are the dimers. They have now bound to the DNA region. So how do you think these thyroid hormones are going to act?
Basically, it will act and it is basically for transcription of the.
How? That is the whole process. What regulates that which part of DNA is going to be transcribed and which part of DNA is not going to be transcribed? So we all have got all the cells of the body have got the same genes. Why is it that some genes are activated in some tissues and some are suppressed, they're not active? What decides that? Which is the major determinant of that? The silencing. How do you silence the particular gene? Methylation or acetylation, histone formation. So that is very important. Chromatin formation. We discussed about you've got two types of chromatin. One which is open, which allows the reading, and one which is closed. It's like in the locker. So what happens in the native state is that when you don't have any thyroid hormone, there will be repressors which will be binding in that particular region, and they will say, okay, I don't want any deacetylation, I don't want any acetylation in that regards. And these co-repressors will use HDAC3 to cause it in a lock system. So now these genes will not be woken up unless you have got some change in the configuration activity. So this is a normal situation. Now, what would happen is that when the ligand binds there, as I said, ligand binds to the main unit, which is basically the ligand binding domain, which is a helical structure. Once it binds there, the helical structure changes. And when the structure changes, it will push off the co-repressors. It can't bind the co-repressors. They will then go off and some new ones will be attracted to that particular area, which becomes the co-activator. And these co-activators will then produce enzymes which will cause acetylation. And this acetylation of histone will open up these things. So essentially what the thyroid hormone is doing, it is just changing the orientation of the ligand binding domain. That change orientation causes the change of affinity to co-repressors, to co-activators, and then they take over and start doing work there. Now, which co-activators are there in a particular tissue will determine which genes are going to be activated. So this is how you will have tissue specific effect also, which will be there in that regards, and they will then cause the overall formation of the RNA, and the translation will be there in that regards. Now, what happens as discussed, normally you have co-repressors which suppress the product formation. Once you have thyroid which is binding to the receptors, it will open up that production. Now, do you have always stimulation by these products? Do you think of some situations where thyroid will suppress some genes? Can you think of some areas in which thyroid will suppress some genes? Of course, there will be many, but one is obvious. Which gene do you think will thyroid suppress? Think about it. So T3 will go at some region and suppress production of which genes? Anti-RH. So of course, in hypothalamus and the pituitary, there will be a negative feedback. So you need to have a mechanism by which you have repression also. So in certain areas, what will happen is that the structure changes in such a fashion that your repressor come into the action and that suppression continues. So that is an important thing. Or what can happen is what is known as trans-repression, in which binding of hormone to the receptor will result in suppression of other areas as well. So this is important thing to remember. So this negative feedback is through this suppressive pathway. So you have activating pathways and suppressing pathways which are there from that regards. And this is particularly for TRH, TSH alpha and beta in that regards. So there, as I discussed, largely there are two major TR1 and TR beta 1, alpha 1 and beta 1, which are the most important. Alpha 1 is pretty much there in most of the tissues in which the thyroid is acting. So if we talk about brain, muscle, heart, liver, everywhere it is there. Beta 1 is largely in liver and kidney. And then you've got beta 2, which is there in the pituitary, hypothalamus, cochlea, retina, important areas in which you will have different neural mechanisms from there. So let's start one by one as to what does thyroid do to different areas. What do you think it does to the chondrocyte? It increases the proliferation of which part of chondrocytes? So it is in a way a growth stimulus. It will stimulate that. So it will mainly work at the hypertrophic chondrocyte predominantly, and it will also increase collagen production. So all the sleeping chondrocytes will start getting activated. But what will happen is also when you stimulate something to do a rapid growth, what will happen? They will die also early. So if you have too much of thyroid, you will have rapid growth, but you will have early fusion of the epiphysis. So thyrotoxicosis will cause tall stature followed by short stature, typically in that regard. So increased proliferation, it will act via the Indian hedgehog pathway, the PTH pathway, the IGF, all those actions are affected, and you will have increased growth, but apoptosis and growth plate fusion. Now, Dr. Manoj, what will happen with hypothyroidism to the growth plate?
In the hypothyroidism, as we have discussed, that chondrocyte growth will be less, and there will be growth secretion will be less. So there is ultimately growth retardation.
So your chondrocyte will be sleeping, but if you sleep for a long time, what will happen?
Then also
they will die. So it's pretty much similar. So if you do too much, also there will be a negative impact. If you do too little, also there will be a negative impact. So if you have very severe long-standing hypothyroidism, you will have the death of those particular growth plate cells, and this will cause stippled epiphysis, as we were discussing in that regards. What will happen to the bone age in hypothyroidism?
Sir, bone age will be delayed.
Very, very delayed. But when you start treatment, you will have rapid acceleration. And what we will see is that the bone age acceleration will be disproportionate to the height acceleration. So there will be lost height, which is there. And if you have early puberty, that will cause even more problem. So that is why there is theoretical role of delaying puberty in this setting if you have a profound hypothyroidism, which is there for a long time. Now, what does it do to the bone? Dr. Naveen, I think you can switch on the mic. So what is the direct effect on bone first? So is it good for the bone or is it bad for the bone?
So it basically causes bone turnover, increased bone turnover.
And when you have increased bone turnover, you will have bone gain or loss. Why?
So because of the fact that osteocyte formation and destruction, destruction is a rapid process when compared to that of the formation. So ultimately we have bone loss.
So basically, thyroid has a major impact on the osteoblast, but it also through the various pathways will also trigger the action on the osteoclast. So the osteoblast action is more like bone formation, which is in the form of osteocalcin, IGF-1 and alkaline phosphatase. But osteoclast is also active. So you are forming and losing. So that is why you will have in acute stage, you will have bone loss. So if you have thyrotoxicosis, if there is over treatment of thyroid in hypothyroidism, bone loss will be there. What will happen to bones in hypothyroidism?
So there will be decreased bone formation.
So overall formation will be less. So turnover will not be increased, but anyway, you are less formation. That also is bad from that. So both hypo and hyperthyroidism are bad for bone. But if somebody asks you what causes low bone mass or osteoporosis, it is predominantly thyrotoxicosis, not hypothyroidism, because there the size, everything will be low in that form, in that regards as well. There is also, of course, as you said, effect on calcium absorption as well as calcium absorption from the gut and that. So you will have calcium deficiency. So thyrotoxicosis will cause low bone mass, hypothyroidism will cause low turnover, and that can cause a problem. Now, what do you think are the effects on the heart? Sign.
So in a normal state, to adequate contraction of the heart, adequate response of the heart to any stress, this will be the normal cases. When increased.
No, I'm talking about normal cases only. So what does thyroid control on the heart? It controls the contractility. So you said contractility. Second
is the conductivity of the sympathetic impulses.
So the tone. So that will determine the rate. So it has got both chronotropic as well as inotropic action. It is increasing the blood pressure and it is also increasing the heart rate. Now, how does it do that? So it acts via the TR alpha 1 receptor. There are specific channels which it stimulates. Sodium potassium ATPase is activated via this and potassium channel. Now, these will cause depolarization and you will have contraction which will happen. Now, can you think of what will be the impact if your sodium potassium ATPase channel becomes hyperactive in thyrotoxicosis?
Increased chances of depolarization.
And so what will it cause? Clinical condition. And I'm talking about contractility. So if you have too much hyperactive sodium potassium ATPase, it causes what? We discussed this in hypokalemia. Hypokalemic paralysis. So this is one of the mechanisms why thyrotoxicosis, especially young males, have a tendency of developing hypokalemic paralysis. This is what is important to remember through the sodium potassium ATPase channel. It also has a negative impact. And so I was talking about how thyroid is suppressing T3, TSH and TRH. It also suppresses some of these sodium calcium exchanges which are against the cardiac contractility. So the net effect of thyroid is to increase the cardiac contractility. There is also a direct effect on the node. So it has an effect on the sino-auricular node to cause heart regulation, and that is why you will have effect on the heart rate in that regards. Now, what will happen in thyrotoxicosis to the cardiac areas?
Increased contractility, increased heart rate, chances of blood pressure being increased.
Wide pulse pressure, hypertension.
Yes.
And
so the chances of hypokalemic periodic paralysis.
Okay, so yes, that is for the generalized body, but in the heart, so of course you said palpitations, heart rate will be more, fibrillation. Which fibrillation? Atrial fibrillation, which is very, very common in thyrotoxicosis, AF, and cardiac failure, which will be a high output cardiac failure. What will happen in hypothyroidism?
Hypothyroidism, there will be bradycardia. BP will be on the lower side.
Is BP on the lower side?
So will not be low, but will be on the lower side.
There is a diastolic hypertension which happens. There is no hypotension in cardiac unless you have cardiac failure. So it will also cause cardiomyopathy in a very, very severe form, and you will have diastolic hypertension. So many adults with hypothyroidism will have diastolic hypertension, which is there. Which thing I've lost? So this is mainly bradycardia, cardiomyopathy, dysuria. Anything else on heart? Very important. So this is not related to this. That's more of a fluid retention. But large heart, think of a pericardial effusion because of hypothyroidism. I have had people who had aspiration of the thyroid pericardiosynthesis done without doing a thyroid function. So this is an important thing to remember from that regard. What about liver? What do you think thyroid does to the liver?
So when there is a deficiency or what?
No. What does thyroid do to the liver? Deficiency is later. Its major impact.
Increases the metabolism, helps in the metabolism.
Of what?
This fatty acid, triglyceride, cholesterol.
So one of the major role is on the triglyceride and the lipid pathway. But you are right in a way that a lot of the enzymes are also regulated by thyroid. And that becomes relevant when you have somebody who has got central hypothyroidism and you start thyroxine treatment, suddenly become sick. What went wrong? Become sick, hypotensive through this mechanism of metabolism that you said. Which enzyme metabolism was increased? So you had a patient who was diagnosed as central hypothyroidism or not diagnosed as central hypothyroidism. You started thyroxine, suddenly went into shock. Manoj?
Cortisol deficiency.
Cortisol deficiency. So there is, of course, somebody who has a covert cortisol deficiency. And once you have started the treatment, the 11 beta HSD2 is activated. And that is causing that. So it increases metabolism. But the major impact, as you said, is on the lipid synthesis, lipolysis, as well as lipid oxidation. So if you have thyrotoxicosis, what will it do to somebody who has diabetes, type 1 diabetes? You will have more lipid, you will have more fatty acid, you have got more fatty acid oxidation. So you will have decay. So if you have somebody, as we're discussing today, if somebody with thyrotoxicosis, will be the first presenting sign may actually be decay in type 1 diabetes. So this is an important thing to remember. Now, in this regards, of course, you will think what will happen if you have hypothyroidism?
So there will be deranged lipid profile.
So you are neither converting it into fatty acids, you're neither oxidizing it. So you will have high cholesterol, high LDL cholesterol. If you have thyrotoxicosis, you are doing everything, burning it out. So you will have low levels of cholesterol. Now, one important protein which is regulated by the thyroid is SHBG. So thyroid excess causes increased SHBG. And some people use this as a marker of functional effect of thyroid. So thyroid increases SHBG. If your SHBG is high, it means the thyroid is working in that regard. So experimental studies do that. Now, based upon that basis, if you have hypothyroidism, what will be the clinical relevance of that?
So if you have hypothyroidism, then SHBG is more. Means your feet
is less. T3 is increasing SHBG, so hypothyroidism SHBG is less. So what will be the relevance of this in girls? If your SHBG is low, what will happen to free testosterone?
Free testosterone is high.
Total will be normal, free will be high, which means it will cause PCOS-like picture. So one of the mechanisms via hypothyroidism causes a PCOS-like picture is actually decreasing SHBG level. So correcting that will improve that in that regards. Now, thyrotoxicosis will cause low cholesterol and LDL, and hypothyroidism will cause high cholesterol and LDL. Now, we have very clearly shown that even subclinical hypothyroidism can cause non-alcoholic steatohepatitis. So I think the basis of this is here only, that your lipid metabolism is completely deranged. So that is why even if you have marginal elevation of TSH, you will have non-alcoholic steatohepatitis. Overt hypothyroidism, often you will find high SGPT. What happens to liver functions in thyrotoxicosis?
In thyrotoxicosis.
You've got a lot of metabolism, all this thing is going on. So what will happen? Cholestasis can happen. And that's why you can have high ALT and other parameters. So both cause high ALT, but the mechanism is different. In hypothyroidism, it is basically steatohepatitis. Here it is more of cholestatic. Your whole mechanism is on an overdrive. So lipid is getting produced, oxidized, everything removed. So that will cause more tendency in that regards in that perspective. What about brain? So what is the major impact of thyroid on the brain or the neural system? Let's not talk about brain in that sense.
Sir, to brain, it has to continuous supply of thyroid.
No, what does the thyroid do?
Sir, as sodium potassium activities, neuronal for the neuronal function, neuronal transmission. It requires
Just the neuronal transmission or function or something else?
growth.
It is very, very important right from the beginning. So if you have somebody who has got, let's say, a MCT8 receptor problem, MCT8 problem, you will have very, very severe brain. So there's issues right from neuronal development to neuronal growth to neuronal differentiation to synaptogenesis to myelination. So thyroid is essential for everything. This transport is very later part in that. So major is when neurons will also not develop. So there are two receptors in the two regions which will act on that. TR alpha 1. So brain is one in which both alpha and beta are expressed. Cerebrum and cerebellum, and TR beta is mainly in the inhibitory areas, hypothalamus and pituitary, and cochlea and retina. Now, what they do is that they cause neurogenesis, migration, myelination, synaptogenesis. So it is very, very important. So that's why we say that the first 3 years of life, when we have the maximum neuronal growth and maturation, we should not touch anybody who has got the thyroid issue, because that will cause more problems in that perspective. So what will happen in hypothyroidism then in congenital hypothyroidism based upon these things?
So there will be definitely developmental delays.
And
Microcephaly is there. And apart from that,
there will be a spastic diplegia. Also, most severe form will present like that, and other things. Look at the other parameters. You will have hearing defect. You will have squint. You can have visual defects as well. So endemic cretinism, which was the word used earlier for severe iodine deficiency, will have all that. So global delay, we'll discuss much more when we talk about congenital hypothyroidism, hearing problem, vision problem, squint, all those things will happen. What are the effects on the acquired hypothyroidism on the brain?
will cause lethargy.
So cognitive issues, adults mainly present with mood changes, depression, dysthymia, that sort of a thing, but cognitive decline, school performance, lethargy, all those things we discussed. And if you are very severe, we have seen patients with myxedema, coma also can present in that regards. So now if we summarize the entire thing, thyroid has an effect on bone mainly via alpha 1 on bone strength and growth. It has an effect on brain via TR alpha 1 and beta 1 both, resulting in neurogenesis, synaptogenesis, myelination, and sympathetic function. So peripheral system also it has an impact. It has an impact on cardiac using TR alpha 1, contraction and tone, sodium potassium ATPase and sodium calcium importer as I discussed. On the adipose side, now this is one thing which we did not discuss, thermogenesis. This is one of the most important part. Which adipose tissue is used for thermogenesis sign?
Brown adipose tissue.
And how does the thermogenesis happen?
So by decoupling the ATP formation.
So this is a uncoupling UCP pathway, which basically uncouples the glucose metabolism and energy production. So what it does is that in a way you will have much more loss of energy which will happen rather than constructive use in that regards. And this is specifically expressed in the brown adipose tissue. And thyroid is a major regulator of temperature. That is why hypothermia will be a major presentation of hypothyroidism. Liver we discussed, TR beta 1, lipolysis, lipogenesis, ketogenesis, all those parameters, and SHBG production, which we discussed is relevant from that regards. The gut, which we did not discuss, what do they do there?
So normally?
Yes.
So normally normal peristalsis will be taken
So
care of.
it is basically TR alpha 1, mainly the motility. So if you have hypothyroidism, you will have constipation, very severe, you will have megacolon, all those things can happen. Thyrotoxicosis, you will have increased frequency there. Now, what about muscle? What does thyroid do to muscle?
So muscular tone, regular activity will be.
So as we discussed, it also has a role in terms of the polarization, depolarization. So that role will be there. So you will have TR alpha, which is expressed mainly contractility. So any muscle contraction, it will have a role same. And CPK inhibition. What does it mean?
In hypothyroidism, CPK will be increased.
So this is the reason why you have high CPK in somebody who has hypothyroidism, and you will have what is known as, what will happen in hypothyroidism in the muscle?
So muscle, culture,
So pseudo muscular dystrophy like picture, lipo picture will be there, and metabolic effect will also be affected on that. So if you have a child whom you're diagnosing DMD, quote unquote, based upon a CPK of 300, 400, like usually there will be thousands. In hypothyroidism, I have not seen thousands, I have seen 500, 600 with calf hypertrophy, pseudo calf hypertrophy. Rule out hypothyroidism before that.